The most important part, what we call as newborn screening, is obviously the process of testing newborn babies with the blood spot screening. This is the most, well-established screening tool in newborns. So we test for genetic, endocrinologic, metabolic, and hematologic diseases which are amenable to screen. So there are certain criteria that need to be met. So like, for example, the test should be specific enough. You should have a confirmatory test to do after the screening comes back. It should be reasonably cost effective, and there should be some form of management approach. I mean, it may or may not be a direct treatment, but it may be change of milk, for example, in terms of metabolic disorders. Thyroid, for example, you need to start the treatment at the earliest, and we have a proper treatment for it. And early, timely detection should make a difference. So that is another factor to be considered in a screening test. There is a lot of research which has been done on choosing these screening tests, and different zones of the world have different tests which are unique to them. So you may find even in the same region, different tests being added in certain centers. Cost plays a role as well in the choice of the lab who is doing the tests. For example, for galactosemia, the more sensitive test is the enzyme test, but some labs may do the cheaper galactose test, which is not that sensitive. So obviously, when we choose the lab doing it and the cost, you have to compare like for like. And it's a battery of tests which are performed on filter paper spots. One interesting fact is that it's done as a pooled sample. So, I mean, that's why the labs are able to do so many tests cheaper. So they run a lot of, say, 100 samples at one time. And if anything triggers as abnormal, they repeat all those 100 spots one by one. This doesn't happen frequently. Suppose 1 to 2% of the spots are abnormal, then the lab doesn't need to repeat too many of these samples. The labs also are very clear in what cutoff will trigger as an abnormal result, and we have to be sure that it's appropriate, especially for conditions like hypothyroidism. It's usually done between 2 to 5 days in most units. Previously, we used to say don't do it before 48 hours because of the TSH surge. But with discharge practices becoming more and more early, we are doing it as early as 24 hours. And we don't see a significant change in the false positive rate, for example, for TSH, because the TSH cutoffs have also been adjusted according to the age of the baby. So, for example, the lab may use a cutoff of 15 to 20 if they are doing it before 36 hours, and adjust the range to 8 to 10 in the older babies. And we may need repeating in the premature babies and babies who are not on feed. So the NICUs have a policy that they do a zero screen because many of these babies are sick. They may need a transfusion. They are not going to be fed for a few days. They are on TPN. And so once they stop the TPN, we repeat the newborn screen. Many preterm babies have slightly abnormal results with 17-hydroxyprogesterone, and this warrants a repeat screen as well. In a bigger baby, for example, if they're on feeds and if you're going to transfuse them, it's better that we take a sample before the blood transfusion. We may need to repeat it after a few weeks if needed, but 3 to 4 weeks is when we want to avoid after blood transfusion. So the most important tests that are included in this blood spot screening is TSH for congenital hypothyroidism, phenylketonuria, galactosemia. I mean, of course, other amino acid disorders are included. Cystic fibrosis, G6PD deficiency, 17-hydroxyprogesterone for 21-hydroxy, which is a type of congenital adrenal hyperplasia. Hemoglobinopathies, I mean, if the test that is done is just gel electrophoresis, you will pick up on the sickle cell trait and alpha thalassemia, but beta thalassemia is not picked up on the newborn screen normally. And in populations like the local population where beta thalassemia risk is high, the locals may be offered a genetic screening for that as well. There is antenatal screening of the parents in these cases as well. One important point to mention here is that the urea cycle disorders are often not picked up in the newborn screen. So we should be alert to that. So we have other conditions like medium chain acyl-CoA dehydrogenase deficiencies, organic acidemias, amino acidopathies. These depend on the baby being fed, and that's why very important that we have the baby on full feeds before we do it. And because we are doing it by 24 hours when the milk hasn't come in much in a breastfed baby, that doesn't rule out. So if the baby comes back later and you have a concern, you can do the screening test. And in babies with suspected metabolic problems, you alert the lab so that they can process that sample at the earliest possible. It's very important that we have a system to take the sample accurately, many times the lab trains our nursing staff on taking the sample appropriately. The blotch should not be too big. It should be appropriately within the circle, and all these spots should be filled. They don't process all these spots. They store a couple of them for future testing if needed. So many population-based studies which are devised can use the blood spot screening for future sampling tests as well. Even if they introduce newer screening tests, they can use the same samples to test for them. How long the lab will store the test, that depends on the local legal system. And we should have a clear way of getting the results back. So now we are getting the reports back fairly quickly, and we see it in the patient's file as well. And there is an alert coming from the lab if there is an abnormal result to the team concerned. So we have in our team, for example, copied all the neonatal consultants and the charge nurses, so that if one is on leave, the MRB is on leave, that is covered. So that is one of the main problems that happens sometimes, that if you have just the reporting to the MRP and it's not a phone call, it's not a critical report, it may get delayed. And the parent should be informed in a timely fashion, in an appropriate way. It's very important that we don't scare them unnecessarily for something that just needs a repeat test. For example, the immune reactive trypsinogen may come back high, but in many cases, it's going to come down on its own. It's not really cystic fibrosis. So we just need to reassure them that it's a repeat test that is needed. But at the same time, we should tell them that the repeat is very important to do. And the good thing is that most of the labs do the repeat test without charging. And there should be prompt action. Depending on the condition, the action should be very quick. In some cases like galactosemia, when the result is categorically abnormal, hypothyroidism is a critical result which should be acted immediately. Before 24 hours, we should be deciding on the treatment. And the 17-hydroxyprogesterone is high in preterm babies due to the age-related changes. And again, we look at the numbers, whether it's very high or not too high, then we can reassure. But you look at the other parameters like the blood glucose, the sodium, and repeat it closer to term if the other parameters suggest it's due to prematurity. So don't repeat it too quickly when the baby is still premature. In terms of galactosemia, I mean, if you're doing the enzyme, you may pick up the Duart variants. So you may need caution with these, but often you continue breastfeeding, and the enzyme level is 10 to 25% of normal. These babies can metabolize the lactose, and we shouldn't overdose it. And that's the only thing. If they need formula, we avoid lactose containing milk, we go for soya milk. But if they are breastfeeding, we just monitor it and repeat the enzyme after 2-3 months, and with the galactose level as well. Again, I warned you about galactose being used as a screening test. Many times it's not going to pick up early on, especially when the milk hasn't come in when you're doing the screening. So if you have concerns, you may need to repeat. And if you have an option of choosing the test, better